Today's lecture is the second part of managing patients who having intra-aortic balloon pump, and the lecture contains weaning from balloon and alarms of the balloon. Anticoagulation. There is no clear agreement about starting anticoagulation in patients on intra-aortic balloon pump, but we should evaluate the risk for bleeding or there is high risk for thrombosis. For example, if the patient post-cardiac surgery, there is high incidence of risk of bleeding, so we can go for using anticoagulation for these patients immediately. And we should assess for the risk of thrombosis, presence of limb ischemia, peripheral vascular disease, decreased capillary filling pressure, patient who did stenting. So the starting anticoagulation is depending on the clinical assessment of the patient and center experience. And generally, patient in CCU, we can use, usually we use anticoagulation, and these patients usually have MI, having a recent stent. A patient in CSICU, we didn't use commonly anticoagulation, especially if we have full augmentation of the full support and full augmentation of intra-aortic balloon pump. This patient has recent surgery and may be at high risk of bleeding. This is a nice diagram for weaning of any temporary device. First, we will assess the readiness for weaning criteria. Then we will initiate weaning trial, then assess for the readiness to take off the machine. For clinical and hemodynamic stability, any patient, since we put the intra-aortic balloon pump, we should every day to assess the stability and the readiness for weaning. And that achieved by an intra-aortic balloon pump, we will not consider aortic and pulmonary artery pulsatility, but the most important thing is mean arterial blood pressure more than 65 and systolic heart rate less than 100 beats per minute. If we have Swan-Ganz, we should consider cardiac index. If we don't have, we will depend on central venous pressure less than 12. Lactate less than 2 millimole, and also we considered good urine output, good perfusion, capillary peripheral pressure. All of this is very important. And end organ like creatinine, urea, and bilirubin and liver function. Also EPG is good, arterial blood gas, the patient is good. And the dose of inotrope and inotropic support is moderate dose. So at that time, we can go for to remove the balloon. Why we insist on moderate dose or less than moderate dose of inotropic support? After removal, we may need rooming to increase the inotropic support to compensate for the removal of the balloon. If there is ejection fraction more than 25, it's not, sometimes we remove less if the patient is improved and can tolerate after chronic ischemia, and a reduction of the severity of the valvular lesion is okay, and we can remove the balloon. Regarding the weaning of the intra-aortic balloon pump, it should be started from the day 0, as we mentioned. There are two methods of weaning which can be used independently or together. First, the decrease in the ratio, which decrease the frequency of the balloon from 1 to 1, then 1 to 2, then 1 to 3. And when we use 1 to 3, we shouldn't wait more than 2 hours, should be less than that because of the risk of thrombosis. And decrease the volume, or which is augmentation, to reach to decrease till 1/3 of the balloon inflated. So this will be better for the balloon to deliver balloon inflation. There is no clear guidelines or evidence to give which is better. Some prefer to use both methods together, starting with decreasing the augmentation, then the frequency. For me, in clinical practice, I prefer in patients with high risk and low cardiac output, low ejection fraction, pre-op or pre-insertion of the intra-aortic balloon pump, to use the two methods together if we have high-risk patient. And the weaning process should take at least in high risk 12 hours preparation for the patient. But in a patient who are low risk, we can wean for 6 hours maximum, decrease the frequency in 6 hours. Another important question, how long we will keep the balloon? The balloon in shock trial, shock 2 trial, the median days of its use is 3 to 4 days. And this is the usual days we used intra-aortic balloon pump. More than 7 days, we will get the complication of the balloon. Also, in some patient who has peripheral vascular disease, severe low cardiac output, the balloon will have a complication. Once we get actually complication of the balloon, we should remove it or starting change the limb or using another modality of mechanical circulatory support. The other question, which should be removed first, the intra-aortic balloon or the ventilator, which the patient is ready for. If the patient is ready for a balloon removal, so we can remove the balloon. Then after 8 hours, we reassess the patient for removal of the ventilator or the reverse. But if we will remove extubate the patient and we will start keep the balloon, so we should know very well that the patient is not delirious, the patient understanding his condition, because presence of the balloon and with a delirious agitated patient and the balloon is in the femoral artery, so this high risk of disconnection or decannulation. So we should first assess the patient for that. This another diagram, nice diagram for removal of all temporary device and especially for intra-aortic balloon pump. And if we find a patient fulfill criteria for hemodynamic and clinical judgment for weaning, so we would put the patient now for standby mode for intra-aortic balloon pump and see if it's okay or not. And we should know that we shouldn't put standby mode for intra-aortic balloon pump more than 30 minutes. And see if the patient's okay, the dynamics is okay, tolerating the dynamics. There is no tachycardia, no arrhythmia, no change in the current situation of the patient. And we have rooming regarding the inotropic support. So now we will start to reduce the ratio from 1 to 1 to 1 to 2. Then if the patient is more risk, we will go to 1 to 3. Also, there are several trials regarding the weaning. Some of them decrease the volume of the balloon itself by reducing the augmentation type and combine it with the reduction of the ratio. Some prefer also to use a ratio only 1 to 1, to 1 to 2, to 1 to 3. For me, I use both of them, ratio and augmentation, in high-risk patient and patient who are with poor function per the using of intra-aortic balloon pump. So at that time, I will use both method to be sure that the patient is tolerated to remove the balloon. Successful removal of the intra-aortic balloon pump depending on adequate weaning procedure and assessment of the patient, and usually to have over 12-hour period, as we mentioned before, for better to a balloon removal in high-risk patient. We should assess the distal circulation several times before and after balloon removal, and periodic assessment of distal circulation is recommended after the removal of the balloon. Intra-aortic balloon removal. The catheter and the sheath should be removed as one unit. Never try to remove the balloon through the sheath and leave the sheath. Then, while removing the balloon, we should apply digital pressure above the puncture site here, allowing free proximal bleeding for a few seconds to ensure the patency of the vessels. Then we apply pressure above the puncture to compress the site of the balloon to avoid bleeding and secure the site of the insertion of the balloon. Steps during removal of intra-aortic balloon pump. High arterial pressure can expel the balloon, so we should hold the balloon inside until we are ready to remove it and adjust the blood pressure. In case if there is leak of intra-aortic balloon is suspected, extreme caution should be done during removal. And if we met a resistance of intra-aortic balloon removal, we shouldn't remove it by a percutaneous approach, and we go for a surgical approach, removing the balloon through arthrotomy. It's better than a percutaneous approach. In this picture, we will find that there is a blood pressure, and this is the map, and this is the augmented pressure. Down here, we will find that augmented alarm, which is giving alarm when the blood pressure drop below this. And this alarm should be adjusted to be 10 or to 8 millimeter mercury below the augmented pressure. Now we got alarm for augmentation is below the limit set. The alarm is limit is set too high or set too low. If the alarm is set too high, we should go down and keep the augmented alarm 8 to 10 millimeter mercury below the patient augmented diastolic pressure. And the alarm limit is set too low, so that's mean that we should increase the augmented alarm 8 to 10 millimeter mercury and check the alarm and check the hemodynamic status of the patient. If we get that alarm that augmentation is below a limit set, so that's mean the intra-aortic balloon pump positioned incorrectly, there is a timing error, or there is balloon break. If we get alarm of intra-aortic balloon catheter restriction, there is restriction or kinking in the catheter or tubing. If the intra-aortic balloon membrane is not completely unfolded immediately after insertion, or the intra-aortic balloon remain in the sheath immediately after insertion. If we got the alarm of intra-aortic balloon is disconnected, the catheter or extension of the tube is disconnected. If the alarm is gas loss in intra-aortic balloon circuit, so the helium loss can be detected due to leak or high rate of diffusion in the intra-aortic balloon circuit. And this is also means there is perforation in the circuit. I explained how to deal with the intra-aortic balloon perforation in the previous lecture. For each balloon, we have two batteries, one working and one for backup. And the sign of a charge of balloon is fully charged. If it's in yellow color, this means we are in high risk. We are going to be a low battery, but high alert and high risk for ending of the balloon will be in a red color, and the balloon should be connected to the electricity. It's very important to differentiate between the two alarms, low battery alarm and sudden shutdown alarm. Low battery alarm will given if there is if the balloon is operating on batteries and the unit is shutting down due to due to low battery. But sudden shutting down alarm will be given, indicate that will shut down due to lacking of a viable power source or problem in the balloon itself. And if we have this is alarm, inflate the intra-aortic balloon pump with 40 cc air or helium immediately and aspirate it immediately. And repeat this every 5 minutes while intra-aortic balloon is inactive till we get another machine. Another important notice, don't change the two batteries together and the machine is not plugged in. Maybe we are transporting the patient, so one should be present and the other can be changed. There are two important alarms: prolonged timing and standby. When we standby exceed more than 30 minutes, we shouldn't allow this time to exceed because it will increase the risk of thrombosis. Autofill failure may be due to no helium, empty tank. There is a leakage in the system, perforation in the intra-aortic balloon pump, and this is, I think, explained well in the previous lecture. The important references for this lecture for more reading about the balloon. Thanks. You can post your comments and questions in the comments below.